Good afternoon, everyone. Thank you so much for joining us today. I am going to ask our chair, Amina Goga, to start sharing her video and we can get started.
Good afternoon, everybody, and welcome to the WeMove Adolescent Health webinar hosted by the Desmond Tutu Health Foundation and sponsored by IAVI. Special thanks to IAVI for the sponsorship. My name is Amina Goga, and I'm the Director of the HIV Prevention Research Unit at the South African Medical Research Council. And as you heard just now, I'll be chairing this session. So thank you all for joining us on this beautiful Tuesday afternoon, and we're really looking forward to an interesting and interactive session. Now, this is the third webinar in the WeMove series, and today we're going to be focusing on sexual and reproductive health integration. We will hear two talks from Heather Jaspan and Connie, followed by a panel discussion. Our speakers will be joined by Nittiya Panuphak and Catherine Martin for the discussion. But to start off, we'd like to know a little more about what you think, and so we have a quick poll question. So if you could open your phone or laptop and go to menti.com as you see on the slide. So you see the instructions on the slide. So it's menti.com and use the code 69913656. And then you'll come across the question. And the question for today or for now is the most suitable place for offering PrEP and STI prevention is through school health services on the premises of high schools, at specialized youth-friendly primary healthcare facilities, at venues where adolescents meet or hang out, like sports clubs, hairdressing salons, or youth centers, or all the above. So a very exciting part of today, go to menti.com, fill in the code that you see on the screen and answer the question. So we'll give you a few minutes to do that. So hopefully you're all getting there. Ah, there we go. First results are coming in. We'll just give it a while. So far, most people say all of the above. So the most suitable place for offering PrEP and STI prevention for youth and adolescents is through school health services on the premises of high schools and at specialized youth-friendly primary healthcare facilities and at venues where adolescents must hang out. So let's see more votes coming in. We're on to 13 for all of the above and 3 for specifically at specialized youth-friendly PHC facilities. I'm sure we can do better than that. 18 votes so far. So just go to menti.com and use the code 69913656. So we'll just give you a minute or so. So it's interesting that nobody's choosing through school health services on the premises of high school alone. Share the code there. Can somebody put the code in the chat bar? I've realized. And the code is also at the top of the slide. $69991. Yeah, there you go. It's in the chat bar now. 69913656. Interesting that no one's just chosen solely through school health services on the premises of high schools or at places where adolescents meet or hang out. Most people are going for all of the above, an integrated approach, and I guess that's what the seminar is about. We still have a few people saying it's specialized youth-friendly PHC facilities. I'll give it 1 more minute for anybody who wants to cast a vote. So the most suitable place for offering PrEP and STI prevention to youth and adolescents is through school health services on the premises of high schools or at specialized youth-friendly primary healthcare facilities or at venues where adolescents meet or hang out, for example, sports clubs, hairdressing salons or youth centers, and lastly, all of the above. Okay, so let's bring that to a close. I hope everybody's, well, I can see that not everybody's managed to participate, but I do hope that you've managed to figure out how to get to menti.com and how to use the code. So this was our question. And what we really saw is that most participants went for all of the above. And I think that really speaks to what we're trying to discuss today. So the integration of sexual and reproductive health services for youth and adolescents. So thanks very much for your participation. So now let's go on with our program. Our first speaker is Heather Jaspan, and we're very pleased to have Heather here. Heather is an associate professor at the Department of Global Health and Pediatrics at the University of Washington in Seattle, and a member of the Center for Global Infectious Disease Research at Seattle's Children's Research Institute. She's also a full member at UCT's Institute of Infectious Diseases and Molecular Medicine. And today she will be presenting on adolescent female genital microbiota and immunity and the effects of hormonal contraceptives. So certainly a very interesting topic, focusing on science and basic science. And it's great to have that integrated into a program that focuses on integration. So Heather, over to you.
And good afternoon, everybody. My name is Heather Jaspan, and I've been asked to present on adolescent female genital tract immunity and microbiota, and I'll also touch on the effect of hormonal contraceptives. I think everybody here knows that HIV prevalence amongst young women aged 15 to 24-year-olds is extremely high in Africa. And here, for example, you can see that up to 40% of women in some countries in sub-Saharan Africa are HIV infected, compared to somewhere around 10 to 20% in males of the same age group. There are many possible reasons for this high risk in young African women. One would argue that behavior does not necessarily play a role because young women all over the world are taking risks during adolescence. There are some possible biological explanations for this increased risk, some of which could be modifiable if we understood them better. For example, sexually transmitted infections are highly prevalent in young African women. Intervaginal practices are used in some, but not all places, for sexual enhancement. And these are an area of hot investigation as to whether or not they may increase HIV risk by changing the mucosal environment. And then the three things I'm going to talk about today are hormones. As young women have a huge flux in their endogenous hormones, but already also start to use hormonal contraceptives, the vaginal microbiota, and the vaginal immune system. So for those of you that don't like heat maps, all I want you to take away from this figure is that cervicovaginal inflammation or high cytokine levels increases a woman's risk for HIV. And in this heat map, you can see that each of the columns is a woman who was enrolled in Caprisa 004. And each of the rows is a cytokine that was measured in her genital tract at enrollment. High cytokine concentrations or inflammation are shown in red and low concentrations in green. And at the top, this bar shows you which women later in follow-up became HIV infected, versus which ones in yellow remained HIV negative. And straight away, you can see a concentration of women who became later HIV infected in the area where there's high cytokines or high vaginal inflammation. So women who later became HIV infected in CAP 004 had pre-infection genital inflammation. And we knew at this stage that about 20% of these women with high inflammation also had an STI, but we didn't know what was causing inflammation in the other 80% of women. At that stage, we hadn't performed any testing for bacterial vaginosis or BV. And then this paper came out This is another heat map, but here I'm showing you the vaginal microbiome of young women from KwaZulu-Natal who were recruited and followed up longitudinally for about 2 years. At enrollment, vaginal swabs were taken for microbiome analysis. And here you can see in the columns, each column is a woman, each row is one of the most prevalent bacteria that were found in the vagina. And you can see that there's 4 main clusters of women. Cluster 1, in this case, is a cluster of women whose vaginas were dominated by Lactobacillus crispatus. Cluster 2 is a much larger cluster of women whose vaginas were dominated by Lactobacillus innes. Cluster 3 seemed to be diverse, but dominated by Gardnerella vaginalis. And cluster 4 is a very diverse cluster of vaginal bacteria. And what they found was that these highly diverse vaginal microbiota types were associated with very high levels of vaginal concentration, cytokine concentrations, significantly more so than, for example, the lactobacillus dominated vaginal microbiomes. And when they followed these women up, despite counseling and condom provision, some of them went on to HIV seroconvert. And you can see that the women in the highly diverse group here who have highly diverse vaginal microbiota and a lack of lactobacillus were much more likely, 4.4 times more likely to become HIV infected during follow-up. So here's a schematic of how we believe that inflammation and HIV and highly diverse vaginal microbiota increase risk of HIV in young women or in women in general. And this is considered an optimal environment where there's no inflammation, there's an intact mucosal barrier. There's a vaginal microbiome dominated by lactobacilli, which make acids that lower the pH. And it's a very acidic environment and very immune or intact against pathogen invasion. On the other hand, when you have genital inflammation, which can be caused by diverse anaerobic bacteria, the pH is altered, the vaginal mucosa is disrupted, and inflammation itself, the cytokines and chemokines, bring in HIV target cells, such as CD4 T cells, particularly those that are expressing the co-receptor, or Th17 type CD4 T cells, which are those very easily infected by HIV, such that if HIV exposure were to occur, they're right here at the surface and not really protected by an intact mucosal barrier. So this is a map showing you use of hormonal contraceptives around the world. And one thing that we need to remember about these young adolescents is that in addition to having to worry about HIV risk, they're also worried about protecting themselves from unintended pregnancy. And you can see that injectable contraceptive use is really concentrated here in sub-Saharan and Eastern Africa. In addition, younger women prefer injectable contraceptives or medium to long-term acting contraceptives because they have a lot of competing priorities and don't want to have to remember to take a daily pill. And the problem with injectable contraceptives, particularly progestin injectable contraceptives, is that in multiple observational studies, they've been associated with an increased risk of HIV. But I must remind you that observational studies are flawed due to biases in women's sexual behavior who choose a certain contraceptive or who know or don't know that they're protected from pregnancy and therefore might use more condoms or less. And because of this, the ECHO trial was funded by multiple funding agencies. It was a huge effort. It stood for Evidence for Contraceptive Options and HIV Outcomes, enrolled 7,800 women ages 16 to 35 who importantly did not want to conceive, so wanted effective contraception, and they were willing to be randomized. And enrollment occurred in 12 sites among in South Africa, Eswatini, and Kenya. Women were randomized 1:1:1 to DMPA IM, which is an injectable progestin that lasts 3 months, levonorgestrel implant, which is also a progestin but is given in an implant in the arm, and copper IUD, which is a non-hormonal contraceptive. Women were followed up 3 monthly for up to 18 months, and the primary endpoint was HIV infection. ECHO found no significant difference in HIV acquisition between the arms. So let's talk about progestin-only injectable contraceptives. The one involved in ECHO was DMPA. It's administered 3 monthly, as I mentioned. But another popular one in South Africa in particular is NET-N, or norethindrone. It's administered 2 monthly. So for that reason, it doesn't have to have as high peak serum levels as DMPA. And what's more there, it's different in its chemistry. And some in vitro studies show that it may have chemical differences in cellular responses in vitro. So we were lucky enough to piggyback on this study called You Choose, which was conducted by Linda Gale Becker and Catherine Gill in Masiphumelele in Cape Town. And they were conducting a randomized crossover trial of 3 different hormonal contraceptives in adolescent females in South Africa as a proxy for delivery of HIV prevention interventions such as PrEP, as in the form of a pill versus injectable versus a vaginal ring. However, they used contraceptives as a proxy for these HIV prevention intervention methods. And so we were given the opportunity to look at the effects of these 3 hormonal contraceptives on the microbiota and immunity in South African adolescents. So here is a study schema. We enrolled and randomized 131 young women aged 15 to 19 years old to NET-N, which is the injectable progestin I told you about, a combined contraceptive vaginal ring, which contained both an estradiol and a progestin contraceptive hormone, and then combined oral contraceptive pills. So they were daily pills that contained both a progestin and an estradiol. We followed them for 16 weeks, after which they were crossed over to one of the other contraceptives. If they had been on NET-N or the pill, they had to go onto the ring because the idea was to check the acceptability of the ring. And if they had been on the ring for the first 16 weeks, they were allowed to choose NET-N or oral contraceptives. And you can straight away see that oral contraceptives or the pill is not very popular amongst this age group. We took mucosal samples for microbiome analysis, for cytokines, which is a measure of inflammation, and HIV target cell assessment at screening, crossover, and exit. And we hypothesized, as this was before the ECHO trial had been unblinded, that NET-N would lead to an increased vaginal microbial diversity, decrease in lactobacillus, vaginal inflammation, and increased HIV target cells in the genital tract of these women compared to the pill and the ring, because the pill and the ring had an estrogen component, which we thought would be protective. So this is a snapshot of the vaginal microbiota at baseline in the You Choose women. In general, this half were BV negative on Nugent scoring, which is a gram stain score to tell you whether you have bacterial vaginosis. And the diverse women were BV positive. And you can see that in this cohort in Cape Town, there's a little bit more, larger number of women who have an Lactobacillus crispatus dominated vaginal microbiota, a slightly larger group of women who have Lactobacillus innes dominated microbiota, and then this much larger group of diverse microbiota, which didn't really cluster into 2 different clusters. And we use the diversity index to measure the diversity of the vaginal microbiota. And you can see that the L. crispatus and L. innes clusters had significantly lower diversity to this diverse cluster. And you can remember, I think, that this diverse cluster in the KwaZulu-Natal study was associated with high levels of inflammation and a significant increased risk for HIV acquisition. Let's look at the baseline characteristics of the cohort in Massey according to the arm that they were randomized to for the first 16 weeks. You can see that in general, they're very young, 17 years, a very high prevalence of STIs, bacterial and trichomonas. About 70 to 80% of them had been using a hormonal contraceptive at randomization. There was a really high prevalence of BV, fairly low condom use, and the distribution of vaginal microbiota clusters was fairly well balanced at baseline. Although perhaps the pill users had a slightly lower, but not significantly so, diversity index in their vaginas. We first looked across all visits at the diversity index, because if we included women at baseline, some were using DMPA and some were using no contraceptive at baseline. And as you can see, the pill users had a significantly lower diversity index compared to any of the other arms. Well, numbers were only high enough in the net-in and ring arm to be significant, but you can see that the pill seemed to be protective against high diversity vaginal microbiota, even compared to no contraceptive. And what's more, although we hypothesized that the ring and the pill would act similarly because they were combined estrogen and progestin contraceptives, the ring did not do the same thing. Again, when we look at intention to treat analysis at crossover, pill users had a significantly lower vaginal microbial diversity, and the distribution of clusters was now significantly different at crossover, with significantly more pill users being Lactobacillus iners dominated, and significantly lower being in the diverse cluster. And what also you could note is that although net-in had a lot of diverse vaginal microbiomes, there was an increase in L. crispatus domination. Okay, I told you we were going to look at immunity as well. And what you can see here when you look across all visits again, you see that the ring in green has significantly higher inflammatory cytokine concentrations in the vagina compared to any of the other users, and even more so than no hormonal contraceptive itself. When you look longitudinally at women who went from the ring, from the pill to the ring, or from net-in to the ring, you can see that there's an increase in inflammatory cytokine concentrations when any one woman is on the ring versus when she's on another contraceptive. And this was not true for the pill and net-in. So it seemed to us that the ring is inducing inflammation. We looked at Th17 cells. As I mentioned, these are highly susceptible to HIV and are found at mucosal surfaces. And what we found is that adolescent females had almost 60% of their cervical CD4 T cells being Th17-like cells. And of these, almost 70% were expressing CCR5, so highly susceptible to HIV infection. When we looked at what happened to the Th17 cell frequency through time, as a woman transitioned from baseline onto the ring, there was a significant decrease in the frequency of Th17 cells, or HIV target cells, which stabilized when she went onto net-in. When we look at the women who went onto the net-in first, there was no real change from baseline to 16 weeks, but when she went then onto the ring, there was a significant decrease in Th17 cells. So in summary, I think I've shown you that there are biological reasons for a high HIV risk in sub-Saharan adolescent females, including very high rates of diverse vaginal microbiota, as well as a plethora of HIV target cells in the female genital tract. I think I've also shown you that hormonal contraceptives may influence mucosal immunology and microbiome and may be a modifiable risk factor. For example, pills may improve vaginal microbiota, and use of vaginal ring may cause inflammation. But there's definitely need for more integrated research on HIV and pregnancy prevention for adolescents in our setting. And with that, I'd like to thank Dr. Bala, who did a lot of this work, as well as my collaborators, Joanne Pass, Melinda Gale, Becca, and Catherine Gill on this project. Ilu Konstantinos did a lot of the immunology. And I'd like to thank Desmond Tutu, the Department of Health, for allowing us to use their facilities and for their collaboration, as well as the funding for the study. And last but not least, I'd like to thank the young women who took part in our studies. These aren't them. This is their community advisory board at some stage back a few years ago who represent them. Thank you very much.
Thank you, Heather, for that presentation. It really gives us a lot to think about. And I know you said that more research is needed, but I think you've highlighted some critical issues that we need to look at as we expand the research area around contraception and contraception for young women, so adolescents and young women, and how we counsel and what options we provide to them. So thanks so much for that. We will have time later to discuss, so I'm going to move us on now. And now we're going to shift gear a little, and we're going to watch a short movie. The movie is produced by Jessie Flynn, who's a filmmaker from Cape Town. Her work focuses on female-driven stories, with a particular emphasis on ideas surrounding girlhood, womanhood, and coming-of-age stories. She's really interested in the space that exists between fiction and nonfiction. So today we will be reviewing a PSA that explores some of the health-related issues that young girls face in schools in South Africa. You'll see that through combined use of live action and animation, the film raises the questions that surround the space of the school bathroom. So let's sit back and watch the movie.
When I had to go to school and I had my period, I felt embarrassing, even though a lot of people didn't know that. But I felt that I had to look behind me like all the time and whisper to my friends and ask, am I still okay, and stuff like that. It's quite terrible to sit in a desk and learn and be on your period with period pains. Sometimes you feel like laying down. You lay down and it's a problem because teachers start getting on your case or they put you out of class sometimes. I find myself in that time of the month that I get my period unexpected. I don't have money. I find myself that where I don't have money to buy the pads or tampons, whatever I use. So it's kind of hard. So I have to go around borrowing money from certain people to buy myself pads.
Boys can't control what they do, and the girls, we really can't control what happens in our bodies. And some people can't afford it, and I don't know, maybe they just bleed through things and people make fun of them, especially when they're at school. to silence everyone down with a female voice, because it's like men when their voices crack and they have this loud voice and they can silence the whole place, but girls, like, we have soft voices, and sometimes people just think we're there to make everything better, but no one makes our problems better.
Thank you, and thank you, Jessie, for putting that together. Jessie is here, and so Jessie, would you mind putting on your video and perhaps saying something, make a comment, or just speak about your experience of putting together this movie?
Thank you so much. Hello, everyone. It's such an honor to be here to be presenting in this series. So first of all, thank you so much for having me. Yeah, so I'm going to try and keep this brief, but basically, as mentioned, I'm a documentary filmmaker from Cape Town. I did my undergraduate at the University of Cape Town, and I just completed my master's at Stanford University in the US. And so my work focuses on issues that women face, and in particular, in recent years, issues surrounding reproductive health. The film that you just watched examines the issues surrounding accessibility to sanitary products for young girls in schools in the Western Cape. At the time of making the film, which was in 2017, many schools in the Western Cape did not offer any free sanitary products for students who bled. And so, like the rest of my work, this film uses a statistic as a springboard to raise questions surrounding how these issues affect individuals in their everyday lives. For this project, I spent many months going around to schools, talking to young girls, and what emerged was how deeply taboo many of these conversations are still today for many young girls and people in general in this country. So the space of the bathroom itself emerged as an icon that doubled as a safe space for stories to emerge and to be shared, but also emerged as an extremely fraught space where so many young girls have to experience the social stigma of going through the experience of having their period for the first time alone without any resources available to them. And the film seeks to raise questions and to lend a voice and a platform to these young women who were so brave to share their insights and their experiences. Thank you.
Thanks, Jessie. Yeah, that's incredible how you've taken that and, taken that and used it to make these little documentaries to try and get the message across using real images and real experiences. Yeah, so thank you for sharing that with us, and all the best with your work as you move ahead. We'll look out for more movies from you to highlight these highlight these things that we often take for granted, that we don't pay attention to. So thanks very much, Jessie, for that, and all the best. But we will come back. We have question time at the end, so don't go away. So next we move on, and we'll move along in the agenda. And now we have a second speaker. It's Professor Connie Celum, who's a professor of global health, medicine and epidemiology, and director of the International Clinical Research Center and Center for AIDS Research at the University of Washington. She's an infectious disease physician, epidemiologist, and clinical researcher, and her research interests focus on HIV prevention strategies, including HIV pre-exposure prophylaxis and prevention and treatment of sexually transmitted infections. She will be presenting on PrEP in young African women, early lessons learned. So over to you, Connie.
Thank you so much to the conference organizers for inviting me to summarize some of the early lessons learned from delivering oral PrEP to young African women. I'm from the University of Washington and have had the privilege of collaborating with Dr. Linda Gale Becker and Dr. Sinead Delaney-Moretley and other colleagues in South Africa. And I think we collectively have learned quite a bit over the last several years. So the key questions are, will young African women take oral PrEP? It was only about 5 years ago that many people sort of thought that was a foregone conclusion that they wouldn't or couldn't. And so we'll talk about that. We'll talk about what strategies support higher adherence and persistence with oral PrEP in young African women. What impact does PrEP have in this key population, and what delivery methods are promising? And that's where I'll touch on some of the issues around integration of PrEP in other service settings that reach young women. So I'm going to briefly touch on 3 projects. First is called HPTN 082, which was really the initial PrEP delivery project in young South African and Zimbabwean women 16 to 25 years of age. Secondly, a project called REACH, which is a crossover study of oral PrEP and dipivering ring among 16 to 21-year-old young women in South Africa, Uganda, and Zimbabwe. And then lastly, a true PrEP delivery project called POWER that was looking at models of delivery of PrEP, mobile van, youth-friendly clinics, family planning clinics in South Africa and Kenya. So first with HPTN 082, we were looking at whether or not women would actually take it. And this study was designed like in 2016. And at that point, it was really an open question, and PrEP was not adopted there were not national guidelines. And so the demonstration project was trying to understand, would women take it? What are the characteristics of women who come into a PrEP demonstration project? And could we improve PrEP adherence, which was low in the clinical trials, by using drug level feedback? And we enrolled women based on a voice risk score greater than 5 or greater than or equal to 5, and that they showed some indication of being ready to do something for HIV prevention based on a scale that we developed from adopted and adapted from a treatment readiness scale. And one of the first things we found was actually, to our, and I think many people surprised, that over basically 95% of women who came to this study in Harare, Cape Town, and Joburg initiated PrEP. So that was quite high. We found that the risk score also indicated that we were reaching women at risk. The median score was 7. That's associated with a 5% HIV incidence in prior cohorts. Condom use was quite inconsistent in the majority. STI prevalence was quite high, higher than I think many of us expected, 30%, and we'll come back to that. Intimate partner violence was also common. Depressive symptoms were reported by almost half. And really, these were women who were new to the idea of taking something for prevention, especially a pill. Very few had taken oral contraceptive pills. We then looked at whether or not drug level feedback, sort of using these wireless signals, would help women be aware of their adherence and motivated to do better. And so we broke down the intracellular drug levels of tenofovir diphosphate, the main metabolite of the active metabolite of tenofovir, into these 3 categories, and then tried to make it really simple message. Red, if you're not having any detectable drug level, looks like you haven't taken it. Is it something you still are interested in? And if yes, how can we help you? Yellow, you're getting some drug level, but maybe not enough to protect you. How can we help you do better? And then green, positive reinforcement for having a high level of adherence. Not perfect, but high. And what we found, because we randomized women to either get the drug level feedback on top of adherence clubs and counseling and two-way SMS, and we found that there was really no difference in those who did or did not receive drug level feedback in their overall adherence at 3 months, at 6 months, or 12 months after PrEP initiation. So it was not statistically significant. We also found that at 3 months, about a quarter of women were taking tenofovir and tricytidine with high adherence, as we defined by 700 femtomoles per punch. And that number started to decline at 6 months and then went down to about 10% at 12 months. So For a subset of women, they were taking it well enough to presumably have good protection, but it did not change based on whether or not they received drug level feedback. We also found that PrEP adherence clubs were really popular, that they were peer-led, they were optional. This is one photo taken at the Emma site in the Cape Flats, and almost 100 women showed up to this one. They were dynamic, and women really participated and talked about their concerns about PrEP and adherence, shared issues, and it was an opportunity for clinical staff to address rumors and myths and problem-solve adherence challenges. So this peer support seemed encouraging and something that we should be thinking about how to adopt as we scale up PrEP. So in summary, we found in HPTN-082 that PrEP initiation was high. Over half persisted with PrEP through 12 months. The majority of women had some detectable tenofovir, but only about a quarter to a fifth had high adherence. Drug level feedback did not change adherence levels. And notably, using a counterfactual, we expected about a 4% incidence in this population and only observed a 1% incidence. And this was in a context of a cohort who had very high prevalence of curable STIs and moderate adherence. So maybe the package of services, not just PrEP, but the STI screening, the counseling, peer support, helped women adopt more effective preventive behaviors. But we also concluded from this study that we need to do more to support PrEP use and also find less adherence-dependent formulations for this populations. We did another study called 3Ps for Prevention in Massey, south of Cape Town, where we tried to see whether drug level feedback with incentives in the first 3 months would improve PrEP adherence. And that, I won't show you the data, but we found that basically, again, there was some trend that incentives helped, but they were very short-term in their effect, and the adherence levels were very similar to HPTN-082. Then the next study that is just finishing up now is called the REACH study. And this was designed to really look in younger users, 16 to 21, whether or not they're in a crossover study of the dapivirine ring and oral PrEP, we could get higher adherence. And we used a menu-based approach to adherence, which I'll show you. So they were randomized to either get the dapivirine ring monthly for 6 months or daily oral tenofovir and tricytamine for 6 months, and then crossed over to the other and then given a choice period. We gave them adherence support choices: daily text messages, weekly check-in, either by text message or phone call, peer buddies, adherence support groups in person or online, and additional counseling visits. And once the study is fully concluded and early in the next year, we'll look at which of these adherence support strategies seem to work the best. One thing that was really exciting, and this was presented by Dr. Lulu Nair at IS in July, is that actually 50%, over 50%, had the highest adherence rate, both for oral PrEP and the ring, and almost another little over 40% in the two groups had some use. So the adherence was even higher than with what we had seen in HPTN-082 and 3P, and very low rate of no use. So we were very encouraged to see these data, and we look forward to learning from the choice period when the study is concluded next month. Lastly, I'll touch on the POWER study, where we were really trying to do a research light touch and really understand about PrEP implementation in non-research settings. And this study was conducted in Cape Town in the 22 teen truck out in the Cape Flats, as well as in a standalone primary health clinic in Johannesburg, in Johannesburg at Ward 21, as well as at a busy central downtown urban primary health clinic, and then in Kisumu in 2 family planning clinics. And in this study, we enrolled over 2,500 women across the 3 sites, median age of 21, most were single, and sexually active, and very few had a known positive partner. 2/3 had a partner of unknown status. Seldom was condom, the condom use was again intermittent, and most were on contraception, and about half had been pregnant before. We found again that STIs were very common. In this case, we found that about 1 out of 3 had chlamydia and 1 out of 10 had gonorrhea, with only 7% having symptoms. So again, we're seeing the very high burden of STIs, and we believe that STI screening and treatment needs to be part of PrEP delivery. Almost over 90% accepted PrEP on the same day, and it varied a little bit by site, but it shows that same day PrEP initiation is feasible. What we found in this cohort is that only 1/3 persisted through 1 month, although another about 15% stopped and restarted. So overall about 1/3 continued with PrEP through 6 months. So I think the real message is PrEP persistence and adherence are where we need to be focusing our efforts. And there are a lot of barriers to adherence and persistence: scheduling, holidays and exam periods, travel, real and anticipated side effects, community PrEP knowledge not being so high when we did these studies, ability to disclose their PrEP use and get support from peers and family and maybe the partner, and simple, convenient refills. One of the things we did in the POWER study is try to see that whether or not a decision support tool might improve women's understanding about what they were doing by initiating PrEP. And we adopted a tool that had been developed for contraceptive decision-making for HIV prevention and PrEP decision-making. And it gave quotes from peers about why they might want to think about taking PrEP, what their different options for prevention were, and then a lot of very simple ways of explaining what they needed to know about PrEP, the good stuff, the annoying stuff, stuff not to worry about, rather than giving percentages and numbers, really putting it in simple terms that hopefully would give women more confidence in what they were about to take, and then addressing myths and misconceptions. And what we did, sorry, this seems to be very sensitive. We did a randomized trial within the POWER study in the urban primary health clinic in Jeffystown in downtown Johannesburg with 350 HIV uninfected women. They were randomized by day to either get that PrEP decision support tool that I just showed you, or general health website. And we looked at both PrEP uptake and persistence. And we found that basically there was no difference in PrEP uptake, but which was very high. It was over 90% in both groups. But we did find a 2-fold increase PrEP continuation at 1 month in those who viewed the PrEP decision support tool. So maybe these kind of simple to administer patient-facing decision support tools can also be integrated into PrEP delivery and help improve persistence. So in summary, say that young women clearly are a priority population for HIV prevention, given the ongoing high HIV incidence. The first generation, namely daily oral PrEP, has shown us that we need demand creation, we need integrated service delivery models, and we need to understand the needs of both users and providers. Young women have challenges, but they also seem highly motivated to do this and have agency. They have high uptake, over 90 to 95% in these different projects that I've shown you. They're, I think also we should take note of the fact not only is risk behavior high, but also depression and rates of intimate partner violence are high. And so as we start thinking about PrEP delivery, we may also need to do better at trying to address depression and intimate partner violence in women who are presenting for PrEP. We have a very high prevalence, between 30 to 39% of curable STIs, most of whom were asymptomatic. So syndromic management would miss them. So we also need to move on the STI agenda and try to address how to diagnose and treat STIs in this population who have high risk of infertility if they're not diagnosed and treated. And we need to recognize that oral PrEP isn't for everyone. It's a lot to ask someone who's having sex on average once a week to take a pill daily. Increasing options such as a dapivirine ring and cabotegravir long-acting and other formulations currently under study will hopefully increase uptake and effective use of methods. So we learn as we go. We learned that drug level feedback, as much as we thought that might give women a boost and improve their adherence, it did not. Maybe that's because it was retrospective and hard to remember what you were doing when the blood sample was drawn. Maybe urine point of care tests will be better. We found in REACH that frequent contact and adherence support choices appear to have really improved adherence and were well received, and that half achieved very high levels of adherence both to the ring and oral PrEP, and that PrEP is Empower. We learned that PrEP is feasible to implement in family planning clinics, adolescent vans, and primary health care clinics, but that a light touch may not be enough to retain adolescent girls and young women in PrEP services. We need to find ways to keep them engaged. And I think overall our lessons from PrEP delivery to African young women are that we need to simplify and streamline, minimize the time and burden that we impose on women by starting PrEP, make it non-stigmatizing by integrating PrEP with reproductive sexual health services, and demedicalize PrEP by finding ways to make it easier for women to initiate it, continue it, not having to come to clinic if possible, through giving other mechanisms of storing products so they don't have a bottle of pills that can convey that to someone that maybe they're on ART instead of on PrEP. So little simple cosmetic-like containers. What's up for peer support groups? Community PrEP resupply is being studied, similar to what's been very effective for ART groups. Pharmacy pickups and HIV self-testing. So there's a lot of work going on in this space of how to demedicalize PrEP. And then I think the other thing we need to recognize is that PrEP cannot be one size fits all, that we have the pill, the vaginal ring is beginning to be implemented in some countries, and that'll give women a choice. The FDA and other regulatory bodies are reviewing the data on injectable cabotegravir, and there are other products that are under study. So a pill a day is not the ideal regimen. We learned that with oral contraceptives, and I think we're learning that with PrEP. There are a subset of women who can take it well and take it well enough to get protection, but we also need to be prepared to how to offer choice of new longer acting PrEP prevention options that are coming on board. And no single formulation will work and be workable for every person, so choice will be important. We hope that this decision support tool approach will also help women make better informed choices. So I just want to thank my colleagues in South Africa and the US and Kenya who've collaborated on these different projects and the funding sources that we've had. And with that, I thank you all for your attention.
Thank you very much, Connie, for synthesizing those studies so beautifully and really bringing forth the issues that we need to pay attention to, particularly engagement, simplification and streamlining, integration, and the fact that not one size does not fit all. Before we go on to the discussion in this webinar, we have a second Mentimeter poll. So if you could look in the screen, you'll see menti.com. Use the code that you see on the screen and answer the questions. In my opinion, the question is, in my opinion, the biggest hurdle to preventing HIV infection, STIs, and unplanned pregnancy in youth and adolescents is, and you must choose one. So menti.com and use the code 69913656. We'll put that in the chat bar as well. So let the opinions keep coming in. Yep, we're waiting. I've just put the code in the chat bar. So menti.com, there we are. So let's see. It's not very big on my side, so let me see if I can do full screen. Better now. So we've got 9 votes so far. Yeah, keep it coming. In my opinion, the biggest hurdle to preventing HIV infection, STIs, and unplanned pregnancy in youth and adolescents is, so I don't know what appears on your side, but there's a big square in the center of mine, so I can't see the screen, but there we go. So 9 people have voted for poor advocacy and communication about sexual and reproductive rights. Okay. So as we bring the poll to a close, any last voters, please cast your vote now. We're looking at 3, 4, can't see the screen very clearly, so I'll go to my version of it. 9 for poor communication, so poor advocacy and communication. So as we go forward, let's get to the discussion, and I see the votes are coming along. It seems like poor advocacy and communication does seem to be the highest. So let's move on now to the panel discussion, and I guess in the panel discussion we can tackle some of these issues. So the first question, the second question that you had to answer now, and then there's some questions in the chat bar. But before we go there, I'm going to ask the speakers to perhaps put on their videos. And thank you very much for those very interesting talks. We will have 2 panelists, Dr. Nittiya Panuphak. So if you could please switch on your video. And Dr. Catherine Martin. Dr. Nittiya Panuphak is the Executive Director at the Institute for HIV Research and Innovation in Bangkok, Thailand. She provides ongoing research support to various studies as Principal Investigator or Site Principal Investigator. She's also the International AIDS Society Governing Council Representative of Asia and the Pacific Islands. And Dr. Catherine Martin is a Senior Technical Specialist at the Wits Reproductive Health and HIV Institute. She's a medical doctor and epidemiologist with expertise in adolescent and sexual and reproductive health, biomedical HIV prevention, HIV management, and health system strengthening. So I'd first like to go to the panelists and perhaps go through you one by one. So Dr. Nittiya Panuphak, would you like to make a comment about the presentations and about anything that arose for you?
Thank you very much, Amina, and thank you for the organizer for inviting me to be part of the this very interesting webinar today. Thank you very much, and I am impressed with all the presentations as well as the short film just presented by Jess. To me, it's very interesting to hear about different service delivery models that we have seen in different studies, and I would say that why we are discussing like different service delivery models, which we I believe all of us here, after hearing the presentations, will aim towards having an integrated services, because we have seen such a high burden of different health aspects of the young girl, adolescents, women. So by looking at service delivery models, I would also encourage us to also discuss this by looking at the building blocks of the differentiated service delivery models, the who, the where, the when, and the what, and beyond thinking of the what and the where. I think the equally important things, or even like the more important thing is thinking about who will be the one who provide these services, because we all know that when we talk about PrEP, when we talk about reproductive health, sexual health, judgmental attitudes, as well as like the stigmatizing environment of the service is really the big barrier of people coming in to the services. So regardless regardless of where you are providing the services, in the clinic settings, outside in a mobile clinic, or in a drop-in center, it really depends on who are providing the service. So I would say that, for example, having a mobile clinic outside, but this is still provided by doctors or nurses. This may not be very much the ideal service delivery model that we can aim for a stigma-free or judgmental free setting, and be something that we can think about scaling it up at a nationwide level. I think I've just stopped it there. Thank you very much.
Thank you very much for those comments, and I think we'll come back to some of the issues that you've raised. I want to first just take any comments from Catherine. So Catherine, over to you.
Thank you, and thanks for the opportunity to be part of this very interesting discussion. I think that we all know that integration is really, really critical, and integrating service helps us to improve access and uptake of the range of services for young people. And I think it also allows for us to offer a client-centered services, as well as improving efficiencies, which are really important when we take these things into real world settings. I think as has been mentioned, a one size fits all approach is unlikely to work. We're going to need a range of different models and products. And I think the key here is choice for our young people, giving them a choice of how they'd like to receive the services, and what kind of product would suit them best according to their lifestyles. And I think that we also need to acknowledge that that may change over time. What is suitable for a young 15-year-old might be quite different to someone who is 24. And so their preferences and their vulnerabilities may also change over time. What we've seen in some of our programs is certainly, some preference for more self-care and self-led options, but there are those who would prefer a more healthcare provider-led option. And so I think we need to just look again at making sure that the platforms and delivery options offer a variety. I think also what's important in terms of integration is that integration happens at all levels, right? From the demand creation through to screening, service provision, and linkage onto other services. I think that we can tend to have a bit of a siloed approach, particularly when it comes to some of the demand creation and some of the information that we give young people. And so I think making sure that it's integrated at all of those levels is really important. And then I think in terms of the health systems issues, those also, as we take things from trial settings and move them into real world settings, are really important. If we're going to offer a range of options of products, we need to make sure that they are then available in the clinics, and we need to make sure that our health care providers are trained and capacitated in order to receive clients who are coming wanting to receive a range of services, and that they're capacitated to be able to provide that. I think as Connie had mentioned, the STI issue is a big one, and I think our current approach has limitations. So I think we'll hopefully be doing a lot more work around the STI and integration of STI services for sexual and reproductive health. Yeah, and I think also just picking up on what Connie said about simple tools, which could really help users to navigate the choices that are available, and then to choose something that suits their needs. As I said, bearing in mind that may change over time. Thanks.
Thanks, Catherine, and thanks to both of you for just reflecting on the two presentations and then offering your insights as well. I want to bring in the two presenters as well. I know that Connie may not be on, but if you are on, Connie, then please feel free to switch on your video and participate as well. But Heather, I'm assuming you're still on. So perhaps if you could switch on your video. And Jessie, please also feel free to chime in from your perspective, because you bring a different perspective to the discussion as well. So some of the questions that have come up in the chat relate specifically to some of the presentations. And the first question was around the assignment. So when you measured, Heather, the inflammation in the vagina, how were people assigned to the groups, and did you find that there were specific differences? And so based on that, do you have any conclusions that you could draw based on how assignment could be? So should assignment be based on choice, or should it be a combination of my personal choice plus what is my biological state? Because that might increase or decrease my risk in relation to a particular modality of contraception. So perhaps I'll throw that question out there first. And Heather, maybe you can start, and then perhaps the others can give their insights as well.
Sure. Can you guys hear me?
Yes.
Okay.
Yes. Yeah.
I think, well, first of all, the question was, so we randomized the women, but we also gave them the option to try the ring, and because none of them had ever seen the ring. And if they really didn't like it, they were allowed to switch to another modality. We did a lot of education around the ring, and we found that at first the young ladies were quite afraid of it. But with time, they got used to it. So, and in the end, Catherine Gill did an analysis of all the preference choices that we took from the young ladies, and they all preferred, well, not all of them preferred. So about 60% of them would have chosen the injectable, which they were very used to. But a good portion of them would choose the ring in future. They staged about 40%, 30% of them, and very few wanted to choose pills, daily pills. As far as contraceptives and other options for future for pregnancy and HIV prevention are concerned, I think we do have to offer a choice. I don't think we have enough data now regarding the biological effects of these choices to advise women accordingly, but I do think we need to continue to gather those data in different settings and in larger sample sizes, so that someday we would be able to give informed advice about that.
Thanks, Heather. I don't know if anybody wants to add to that. And if not, let me move on. So one of the things that came across quite clearly from Nittiya, Catherine, and also from Connie was the whole idea of integrated service delivery models and the question of where services are offered and who offers contraceptive, and I guess not just contraceptive, but sexual and reproductive health services. And so I want to throw this out to Jessie, because I think, Jessie, you've kind of got your ears to the ground in making the films that you do. What do you think would be most meaningful? So we're trying to change things, and we're trying to increase access, but also increase use. So what, in your opinion, are the things that we need to take into consideration?
Well, certainly, firstly, just as a caveat, I'm certainly not a health researcher in any way. Yeah. And so anything that I say should definitely be considered along those terms and lines. Yeah, sure. And also just a great privilege to be able to listen in on all of this research. It's absolutely fascinating and so vital. And so I just wanted to say that. Thank you for this also. I think, well, first of all, I made this film in 2017, and I think that it's also noteworthy to say that the sort of conversation surrounding accessibility to reproductive healthcare products, and also just conversations in general, I think that there has been an uptick in it in terms of public conversations and sort of reducing the taboo ideas surrounding these different conversations. And so I think that that's firstly important. And I think that that can be seen sort of on the ground at schools amongst younger people, 100%, even just in the past couple of years. But I mean, something that I did discover personally was that just this issue surrounding stigma is such a huge, huge, huge issue. Just even in terms of the first steps of having conversations with people, never mind even just in terms of asking where they're going to access them. Just the very first step of having these conversations with these girls and saying, hey, you know, this is available to you, this is where it's available. And so I think that I think that a potential sort of solve for this, and the fact that this still lingers, is just having people on the ground in schools, in these different community facilities, who these young women trust and know. I think it always is better when it's someone from the inside, from within a community, rather than someone coming from the outside. And consistently throughout all my research and all my work, irrespective of what the topic is, that comes up consistently, that it's all about trying to find people within their communities who they trust, who they know, who they feel that they can talk to.
Yeah, thanks very much. I think that really provides lots of insight. And as we move forward in trying to reimagine services for adolescents and young women, I want to come back to the points that were made earlier around who provides services. And you're saying young women must trust and they must know these people. So who provides services? And then the second thing is, where do we provide these services? So the question is what? And I think there's a lot that we have to think about in terms of what, particularly based on what Heather has shown us today, where, and I think Nittiya and Catherine have raised the question of where, and then who. And I'd like to invite people from the audience to please offer any questions or any suggestions to answer those questions. So the what we need to think about a bit more. And then when it comes to the who, the where, and the when, do you have suggestions or are there questions for the speakers?
So Amina, if I can chime in a bit here while we are waiting for the others to ask or to share their experience. I mean, I'm coming from working with a population which may be different from all of you here. I'm working more with transgender women and who have sex with men. And one thing that I have seen very, very strongly within the transgender women community is the influence of their sisters. So that means that for us, it's very, very important. Like no matter you are talking about PrEP with no interaction with feminizing hormones, and if you are a doctor, you're a nurse speaking to transgender clients, you will not get it to the level that the community really listen to and listen in a way that they understand what the message is trying to be sent to them. So for us, we use a lot of online trans influencer when we would like to send out message around PrEP, around hormone and interactions between hormones and PrEP, etc., including sexual health aspects. And what I'm trying to say here probably is linked to the where as well. We are talking mostly today about still the physical visit for these girls and women to come into to you, or you go out, but they still have to come out to see you. So I'm thinking that because we all learned from the COVID time, the technology related to self-testing and self-sampling may be what we would want to use more often into the future, because that means that we can bring the where to the client's home. And not just like thinking about the clinic setting. And I feel that like in Asia, the culture of putting something inside your body is really not things that we ever used before. So when we talk about self-sampling from the neovaginal compartment, anal compartment, it's something that we thought it would be would not be feasible ever in our country, but through COVID time, it proved that 80% of our trans women or men who have sex with men actually accepted and can do self-sampling very perfectly. So that's the 2 points that I would like to add. Thank you.
Yeah, thanks very much. I think
Amina,
those are really important points.
Amina,
I see there's a question. Oh yes, go on, Connie. Sorry, I didn't see you.
I was just going to say, I've followed Nittiya's work, and I think it's so impressive. You've really shown that what I would call differentiated HIV prevention services are feasible, community-based services, and with a light touch of the kind of clinical backup. So you can train community peers to deliver services. And I suspect, it would be different with adolescent girls and young women, but I think that what we do know is that, there's kind of this tension between with the high drop off and the fact that there's of PrEP in the first month or so, that maybe the model for young women from what we've learned so far would be that you do need some more initial clinic-based encounter to try to really address side effects, do the STI screening, talk about contraceptive choices, but then once, there probably is a model where you could then do very light touch in terms of the monitoring. Really, in this population, we do not need to be doing creatinine testing. 99+% are normal, and even the Hep B screening. So for oral PrEP, it should be feasible to do community-based resupply and to have less of a clinic-based model. So I think that we need to just learn from some of your work, as well as from the initial studies about how to simplify it. And there should be ways to move further from the clinic and to make it easier for women to continue. What they don't like is they don't like blood draws. And so that's why I say that about creatinine testing. That's a huge barrier. And they really would prefer not to have pelvic exams. So I think the self-sampling for STIs is also feasible in this population. Thanks.
Yeah. Thanks, Connie, and thanks for coming in. Thank you. I see a hand up, Rosemary Zulu. Rosemary, over to you. I think you can just unmute and ask your question.
All right. Hi, everyone. I was struggling to unmute myself. So I am Rosemary Zulu from Zambia, and I think some of the things I wanted to say have been shared by Connie. I wanted to say that we just completed a study called the Yatu study here in Zambia. And what we're trying to do is to provide sexual and reproductive health services in the community. And we saw it work, even though the results are not yet in, but we could see that, like what Connie said, removing the services for adolescents and taking them right in the community where they are, it makes it easier for the adolescent to access. So in terms of who was providing, in our case, we trained some were adolescents and some were young people that were lay counselors, or rather psychosocial counselors. And we had to employ an adolescent nurse, so a trained nurse that was young and energetic, and we had to rent some spaces within the community, which were like youth-friendly services. And we had like about 4 staff, an adolescent nurse, 2 peers, support workers or lay counselors, and a supervisor. And young people were free to come to the hubs and access whatever services that they needed. So PrEP was one of the options. We had contraception and so on. But for things like STIs, obviously we were screening them from the community, but we're referring them to start treatment at the facility. And as well as, STI testing and treatment was done at the facility, and initiation of PAPE and PrEP was done at the facility. And what we learned, just like what Connie said, is it's important. I think moving forward, we are looking at how we can have all the services right in the community, from screening to treatment. Because when we're doing the Yatu study, we noticed that not all the people that we referred to the facility to access STI, further STI screening and treatment received the treatment, because obviously of different challenges, including shortages of treatment, as well as some young people were referring to go and access PrEP and PAPE from the health facilities, couldn't do that because they were, in as much as we had some young people that were escorting them within the clinic, they felt uncomfortable to leave their hubs, our community spaces, to go to the facilities. So in terms of who, I would say that what I think would work is to have lay workers who are peers, who are also adolescents, that can reach out to the fellow adolescents, as well as someone like, a young doctor or a young nurse that can be based at that space, so that young people can have pretty much all the services from there. And yes, I think that would work. And yeah.
Thanks, Rosemary, and thank you for sharing those insights with us. Yeah, I think they're really valuable, and they complement what we've been discussing this afternoon. So we're almost out of time. I don't see any additional questions in the chat bar, and I don't see any hands up. I wonder if we could, Connie, yes, over to you, Connie.
I have a question for Heather. I'm trying to think about how it's this balancing. How do we communicate about what we're continuing to learn about in terms of the microbiome work in the context of echo finding? Should I don't know, I always, maybe because I'm a pragmatic person, I like to find simple ways of messaging it. Do you think it would be accurate to say, based on echo, that that basically, if there are influences of the microbiome, can we extrapolate from your work and the echo findings to say that although that there may be differences in how hormonal contraception formulations influence the microbiome, it doesn't appear to be big enough at a population level to increase risk, so that we can maybe make the messaging pretty simple about letting women know that from echo, there's really their choices, they don't have to worry that their choice is going to change their HIV risk. I guess I'm trying to figure out, how do we make it simple enough for people? It's so hard to explain the microbiome.
So a number of things. So echo only included DMPA, copper IUD, and levonorgestrel implant. And I think the idea is to try and increase our the options for women, the sort of menu for women around the world, from just those what's available now. It's a multi-pronged question, because in echo, we did find that the copper IUD altered the vaginal microbiota quite significantly, yet there was no difference in HIV risk or significant difference in HIV acquisition between those arms. So I don't think, I mean, we asked the CABs at the sites at which we performed the microbiome analysis what they wanted to tell their participants and how they wanted to feedback. And the only site that wanted to feedback anything was KEMRI. We had KEMRI, Emma Vondleni in Cape Town, and Wits Reproductive Health Institute in Joburg. And we really, we just said to them that we think that the copper IUD may increase your risk of bacterial vaginosis. We didn't say anything about HIV risk. But they chose to feed that back to the participants. But we don't know how long it persists, because we only did it till 6 months. And, you know, but I don't personally think we should go running around telling people anything about what contraceptives do to your microbiome now, until we have more data. But for example, the ring and the multi-purpose technology approaches that can deliver both an antiretroviral for HIV prevention and a contraceptive, those are highly promising for us, for young women. And you know, our findings that they may increase inflammation, or this particular ring increases inflammation, I think it's worth looking at that as we move those technologies forward, just because you know, I think when you introduce a different drug to the ring, it may counteract any effect that the ring may have on the immunity. You know, there's a lot of different things that can change what we found in this particular population, in this small number of girls. So bottom line is, I don't think we should, I personally don't think we should go, I mean, BV isn't fun regardless of whether it's an HIV risk increaser. It also does other things to you. So, I mean, maybe if we found that copper AD, for example, were to increase the risk of BV long term, which we're looking at, maybe it's worth then telling them something about that, but not yet. And I don't think necessarily HIV risk is, we can't tell them anything about that.
Thanks.
Thanks, Heather. Yeah, and thank you for answering that. I think we're almost at the top of the hour. And so I think it remains for me to say thank you very much to all the speakers, the presenters. Yeah, and you've got the acknowledgements on the screen. So thank you very much for Professor Heather Jaspan, for Professor Connie Celum, for the panelists, Dr. Nittiya Panuphak and Dr. Catherine Martin, and for our local artist, Jessie Zinn. And thanks especially to IAVI for sponsoring this webinar. I think what has been brought to the fore today is the possible association between contraception and increased inflammation, and we wait to get more information about the effect that may have on HIV transmission. We've discussed service delivery models and the importance of focusing not just on the what and the where, but also on the who. We've listened to the effect that influences can have, and to the fact that people who provide contraception and HIV prevention services, or let's say sexual and reproductive healthcare services to adolescents and young women, need to engage with them and need to be trusted by them. And then we heard a bit more about differentiated HIV services or differentiated sexual and reproductive health services. So I'd like to thank everybody for all their contributions. Keep looking out for important publications by the speakers and the panelists to inform the way forward. And have a great afternoon. As you exit the webinar, you'll find an evaluation screen come up. Please take the opportunity to answer the evaluation so that we can make these webinars better as we move forward. And then all the best with everyone's work, because I think everybody who's been on the call has a great interest in sexual and reproductive health, and we're all working to contribute in some way. So all the best with the work, and just keep an eye on new publications coming out. So thank you so much, everybody, and have a great afternoon.
Thank you.
Thank you.
Thank you. Thanks, everyone.
Thank you.